This lecture is going to examine the drugs that are defined as the atypical antipsychotics. The reason they're called atypical is because they're second generation antipsychotics and they have a profound effect on serotonin. This is in contrast to the first generation antipsychotics, which were the typical antipsychotics, and they had a profound effect on dopamine. Examples of these drugs include haloperidol, chlorpromazine, loxapine, and a few others. These have significant number of side effects that include movement disorders, anticholinergic effects, as well as cardiovascular effects. The second generation antipsychotics, or the atypical antipsychotics, have much more fewer effects, particularly those associated with movement. The atypicals, or the second generation drugs, from a mechanistic standpoint, do affect both dopamine and serotonin, but they have a more profound serotonin blocking effect than they do dopamine effects. Specifically, the serotonin 2A receptor and the D2, or the dopamine subtype 2 receptor. The drugs in the atypical category include clozapine, risperidone, olanzapine, quetiapine, and ziprasidone. And again, these drugs blockade or block the 5-HT2A receptor, and they're a D2 receptor partial agonist and a 5-HT1A receptor agonist as well. Other drugs include aripiprazole and cariprazine, and then there's another subcategory where you can see 5-HT2A inverse agonism as well as antagonist with no dopamine activity, and that's pimavanserin. So the main antipsychotics are listed here, and then these are some further subcategories based on specific receptor affinities. So let's kind of discuss the differences between the 5-HT1A and the 5-HT2A receptors. So the 5-HT1A, when stimulated or activated, increases the potassium conductance, producing hyperpolarization of the neuronal membrane, and that's going to reduce the firing rate. So then this will reverse the suppression of firing of postsynaptic norepinephrine neurons. In contrast, the 5-HT2A receptor, upon activation, this receptor causes anxiety, OCD, depression, influences energy levels, and so produces fatigue, can drive a lower heart rate and lower blood pressure, as well as produce insomnia and less deep sleep. Atypicals are, in terms of their pharmacokinetic profile, are typically given with food, which tends to increase the absorption of the drug. They do have hepatic metabolism, many through CYP2D6 and renal elimination. CYP inducers and inhibitors can greatly affect the serum levels of any of these antipsychotics. However, one thing to note is that there are not that many CYP inducers or inhibitors of the CYP2D6 enzyme system. Many of the CYP2D6 clinical changes really are coming from polymorphisms that exist within the general population. And then a few of the drugs that are listed here have active metabolites that you can suspect would have some off-target binding. Side effects really come from preferential blockade of the serotonin receptor. So whenever you primarily affect serotonin more so than dopamine, at least in this drug category, you see less CNS effects, but more metabolic type of effects. Other receptor affinities are possible. Some of these drugs have antimuscarinic effects. Some of them have anti-adrenergic, alpha-adrenergic agonist activity, which can produce hypotension. Some of them can block histamine, which can produce sedation. And almost all of the drugs that can produce H1 antagonism are included here. Clozapine and quetiapine have the greatest potential to produce sedation. General side effects, relatively minor. Weight gain, diabetes can be exacerbated. You can see elevations in A1C. You can also see hyperlipidemia kind of being exacerbated as well. Major side effects though include tardive dyskinesias, which is a movement disorder, neuroleptic malignant syndrome, which is reviewed elsewhere, as well as a lowered seizure threshold. Traditionally, clozapine is an antipsychotic, but it's been used in schizophrenia. So we'll come back to this drug when we talk about schizophrenia later. But clozapine itself is really the best drug for the problematic negative symptoms that we associate with some of the more difficult to treat flavors of schizophrenia. It does not produce movement disorders typically, so you don't really associate it with tardive dyskinesias or TDs. More on that later. But it does have additional receptor activities. It goes after the alpha receptor, the H1 histamine receptor, as well as the muscarinic receptor as well. The major side effect that typically is asked on step exams is agranulocytosis. It's really a minor one. It only occurs in like 1% of the population. So you must monitor neutrophils of all patients on clozapine, and it comes with a black box warning. It is relatively rare in its incidence, but when it does happen, it could be deadly. Cardiomyopathies, of course, are also associated with clozapine use, and so that there's also a black box warning for that. There's a lowered seizure threshold, and so patients with a history of seizures, epilepsy included, would not do well specifically on clozapine for any indication. And then patients on clozapine do often drool a lot. It's called the wet pillow paradox. We don't really know how that occurs or why that occurs because it is an antimuscarinic. From a pharmacologic standpoint, it should produce dry mouth, and it does. But at night, for some reason, it can produce the wet pillow paradox. Clozapine was really a revolutionary type drug, and it kind of gave rise to other members of this class through different chemical interactions and chemical modifications of the parent compound. Olanzapine is kind of like clozapine. It's not as efficacious, but it does not produce agranulocytosis as far as we can tell. Risperidone is associated with a dose-dependent movement disorder. Quizapine is also a 5-HT1A partial agonist, and ziprasidone is associated with a prolonged QT syndrome. So none of these iterations of clozapine or modifications of clozapine chemically have made it side effect free, but we've changed the side effect profile in all of these different generations or modifications of the parent compound. Ariprazole has been advertised as an add-on therapy for depression. It got FDA approval in 2007, and it does kind of go after other receptors as well. There's some H1 and alpha-1 affinity there. Sometimes you see, and this is the brand name Abilify, you see it added to SSRI-treated patients as an adjuvant therapy to improve mood and overall behavior.